Let's talk about the kidney stones here. Again, an important topic. First, we're going to do the type of kidney stones. Then we'll see the common features. First, calcium. That's the most common one, okay? Calcium has two types. One is calcium oxalate, other one is calcium phosphate, okay? There are two types of stone. Both of them are radio opaque, which means it's easy to see it on the X-ray. They look like envelope or dumbbells, folks. Okay, you could see that. It looks like an envelope or wedge shape prism, folks. That's a key. Calcium stone is most common, 80% of the time. Calcium oxalate is more common than the calcium phosphate stone, folks. Okay. Now, can results from ethylene glycol, that's antifreeze ingestion. Who do you think that uses antifreeze? These are homeless people in wintertime. What they do is they want to keep their body warm. They don't have money to buy alcohol. So they go to gas station and buy the antifreeze and they drink that. When they drink that, they get every effect what an alcohol will give, plus a kidney stone. Okay, so that's what the antifreeze is for, basically, folks. Okay, they drink that. Okay, $4, a whole gallon. It does the job. Okay, so that's that. Now, vitamin C overuse can do that too. Hyposaturia can do that. Malabsorption in Crohn's disease. I remember for Crohn's disease, its extraintestinal manifestation is your kidney stone, isn't it, folks? That's that, folks. Okay, very good. Now, the treatment. One of the key things, folks, because they have a calcium stone.
How does vitamin C overuse?
Overuse of vitamin C can deposit calcium. So what it does is it increases the excretion of vitamin C in the kidney, not vitamin C, calcium, that causes the deposition of stone. They have to use a lot every day for those people. Okay. Now, treatment. You could do thiazide, citrate, or low sodium diet. Same thing for the other one, but I'll tell you what answer you should never pick on the answer. No low calcium diet. Sometimes what happens, people think, oh, I have a calcium stone, so I should not eat calcium. That's a wrong answer, folks. They should eat the same way of eating calcium. They should never reduce the calcium intake, okay? So if you ever see an option, low calcium diet, you never pick that. Is everybody clear, folks? Okay, and the best answer is always hydration, drinking a lot of fluids. Drinking a lot of fluids, folks, okay? So that's a treatment for both type of calcium stones. Are we clear here, folks? Okay. Now, what's the name of the medication? We said yesterday it causes calcium stone. Type it up. What medication will cause us calcium stone? It's the loop diuretics, right? Because it's excrete more calcium. So you should also know loop diuretics are contraindicated in these patients. Okay, so, all right. Next, ammonium magnesium phosphate. We call that struvite stone. That means it grows inside. Radio opaque. It looks like a coffin lid. If you see the picture, it does. Look at that. That looks like a coffin lid, folks. Okay, those are all ammonium stone. But this is a thing. In kidney, so what liver does, we learned this in biochemistry, liver converts ammonia to urea. Isn't it, folks? We studied the urea cycle. Liver converts ammonia to urea, okay? Liver converts ammonia to urea. We studied that. So that means this urea goes to kidney and get excreted. That's a normal process, normal physiology. Is everybody clear with that? Now, what's happening in the kidney? This urea is being reconverted to ammonia. This urea is reconverted to ammonia by an enzyme called urease. Urease is a special enzyme, but our human body don't have that. So how do you think it's possible? Somebody is bringing this enzyme into the kidney. Those are called urease positive organisms. urease positive organism. There's a specific bacteria, they convert the urea back to ammonia by the enzyme urease. Is everybody clear, folks? So if somebody is getting ammonia stone, they must have an infection in the kidney. If you see here, it's about 15% of the stone caused by infection with urease positive bugs. These are the urease positive bugs, folks, that hydrolyze urea to ammonia and is becoming urine alkalization. Commonly formed staghorn calculi. Staghorn means they grow. Look at the picture, see. So when people have a staghorn calculi like that, they cannot pass that stone. That needs to be a surgery. They need to go cut the kidney open and remove it. It's a simple surgery, but they have to remove that surgery when they remove it, folks, okay? So when you remove it, of course, you have to remove the stone. That's number one. What's the number two? Eradicating the underlying infection. You need to cure the infection, folks, okay? That's very important. So you have to give antibiotic. And keep an eye on the pH. These are alkaline pH stones, folks, okay? So that's the key. That's ammonia. Everybody clear with this, folks? Okay. Now, Monica, go ahead. What's your question? I can't hear you. I cannot hear you. You are muted. Your mic is muted.
I was kind of lost when while talking about thiazide diuretics and then loop diuretics, like why exactly you give.
Because remember, when you give thiazide, it reabsorbs calcium. That's what we studied yesterday. So taking thiazide reabsorbs all the calcium, so you have low calcium in the urine, isn't it? So that's why we give thiazide. Does that make sense?
So I think I got confused because there's a mnemonic loop lose calcium. So how does it pass?
Loop diuretics is different, thiazide is different, two different medications. Loop diuretics works on the thick ascending, thiazide works on the DCT. Refer back to the notes we did yesterday. You know, I always tell, I'm not a fan of mnemonics because half of the time mnemonics can confuse folks. Careful, okay? Thiazides reabsorbs calcium in DCT, which makes less calcium available in the urine. Okay, all right. So that's that. Now, uric acid.
Sorry.
Yeah.
Could you go back to calcium and explain how would you get the, like, what's the difference between the calcium oxalate and phosphate in regards to like how which one develops besides, like, how would you get calcium phosphate? I understand the oxaloacetate from the ingestion. But how would you?
So the calcium phosphate is also, see, calcium oxalate and phosphate is very similar, but only the phosphate group is different. So people can get calcium phosphate also by having more calcium in the urine. It doesn't matter. Okay, so it's almost like that. And you could say calcium oxalate is kind of more specific to Crohn's disease, but calcium phosphate also can. Let's say if a healthy person don't have any other problems, most likely they will get calcium phosphate. So there is no big difference. It's simply calcium. It's just a little different in the chemical structure, but it's all the same way then. Okay. Now, next, uric acid. That's the acidic pH. Now highlight this. I want you guys to be very careful. Radiolucent. What does that mean? When patient comes with a uric acid stone, if you take an X-ray, you will not pick that up. Okay. If you take an X-ray, you would not see, because radiolucent means everything will look black. So you cannot see the stone. So if a patient has a typical symptom of a kidney stone pain and you see an X-ray negative, that doesn't mean they don't have a stone. You have to do further testing, CT, whatever, right? So for step one, just say if it is radiolucent, you'll probably do CT and it will pick it up after that, folks, okay? Now, this is about 5% of all stone associated with hyperuricemia, gout people who breaks down uric acid, folks, okay? And also you could see tumor lysis syndrome. If you remember, we studied in hematology. When you have a tumor lysis syndrome, we produce more uric acid, it gets excreted, and it can form the stone. Because the stone forms on the acidic urine, all you have to do is change the pH of the urine to alkaline, and they will not form, they will excrete it. Okay. So opposite pH. Or you could give allopurinol. which will inhibit uric acid formation by xanthine oxidase. Okay, so that's that. Now, calcium is the most common, followed by ammonia, uric acid, and the last one is cysteine. It is the least amount of stone, very rare people form because they have to have a hereditary conditions. Where did we talk about cysteine? If you remember in biochemistry, we studied the cystinuria, right? What does that mean? There's a special protein transporters that reabsorb protein in the PCT, and sometimes they have a defect. Look at this here. There's a cysteine reabsorbing PCT transporter, loses its function, so we lose ornithine, lysine, arginine, and cysteine, folks. Okay, that's the idea. But here, cysteine is getting in the urine and they're forming the stone, folks. Okay, so that's the urine stone. Now, that's also acidic pH, faintly radio opaque. We could see it sometime we cannot. It can also form Staghorn calculi. There's a test. The name of the test is called sodium cyanide nitroprusside test. It's a name of the test, how they do it. If the test is positive, it tells you there is a cysteine stone in the body, folks. Okay. Now you could see here, low sodium diet, alkalinization, and change the pH. That's the idea. Change the pH, that will cure. These are 4 different types. Now, mostly you will get a question in calcium or ammonia. These are the 2 commonly happening diseases, folks. Okay, 100% one question. Now let's see some complication. Now, when we have a kidney stone, the complication is hydronephrosis, pyelonephritis, acute kidney injury. I'm going to go through each of these diseases. We haven't done it. Obstructed stone presents with unilateral flank tenderness. That's a pain in the back. That's what called the flank pain, right? The costovertebral angle tenderness. And the pain will radiate to the groin. Okay, so the pain radiating to the groin, and sometimes hematuria. Why hematuria? Is it a cast or red blood cell? It should be red blood cell, no cast. It's below the glomerulus. Because why? The stone can erode into mucosa and damage, and people can bleed, folks. Okay, that's the idea. Treat and prevent by encouraging fluid intake. Okay, drinking a lot of water that's always the best way to do that, folks. Okay, because what happens, it dilutes it. Okay, so that's kidney stone. Now, these are the different type of stone. Now, let's see the complication you were talking about. Hydronephrosis.
Yeah, I just had one question. What did you say about the low calcium diet?
Okay, so when people have a calcium stone, it's a common mistake student makes. If you have a calcium stone, that means you shouldn't eat any calcium food. So low calcium diet is always a wrong answer. You should never pick low calcium diet as an answer, okay? Because they give you that option. You never pick low calcium diet. Because, logically they think it's a calcium stone, so I shouldn't eat calcium. Does that make sense, folks? So that's a wrong answer. That's what I was trying to tell. Okay, now, we see here, this is, let's say, a ureter. Okay, so I'm just drawing one ureter. Anytime this ureter gets dilated, we call hydronephrosis. That's hydronephrosis. Distension or dilation of the renal pelvis and calyces, usually caused by urinary tract obstruction. Oh, any BPH, we'll see that, folks. Other causes include retroperitoneal fibrosis, vesicoureteral reflex. Vesicoureteral, highlight the vesicoureteral reflex. Let's talk about this, folks. So I'm just drawing the urinary bladder only one side. Okay, so you assume you have it on the other side too. Now, just to I'm covering here basics of your urinary bladder. The residual volume is about 50 ml approximately, which means at empty. So let's say right now you don't feel like you want to go to the bathroom, but you still have some urine in there. Is that clear, folks? And then we collect the urine. The urine comes down, right? The urine comes down. As the urine comes into the urinary bladder, the bladder stretches because that's how they can hold it. Is that clear, folks? when the bladder stretches, we are created in a way, as we stretch the bladder, there's a valve right here. It closes that valve. So every time your urinary bladder stretches, this valve will automatically close. Why? Because when the urinary bladder stretch, it's an indication of urine filling in the bladder. Is that clear, folks? We do not want the urine to go back. It's called retrograde flow. We do not want the urine to go back. Why? This is a sterile urine, folks. There's no organisms. We do not want any urine to go back. Retrograde urine flow, it's always pathology. So every adult, as we hold the urinary bladder expand, that will close this valve. It's made up of a detrusor muscle, right? Your urinary bladder is full of detrusor muscles. That's the normal function. Is everybody clear, folks? So the valve closes. So when do you close the valve? Only when the urinary bladder stretches. Is everybody clear, folks? All right. Now, in kids, it takes about, I believe, 7 to 10 years of age for the valve to be developed. So the kids will develop that valve only after 7 to 10 years approximately. So let's say a 7-year-old girl, until 7 years, there is no valve development. So kids should not ever hold a urine. You know, that's why we tell when a kid wants to go to the bathroom, you always take them. Because if they hold, they don't have a valve, they will go back retrograde flow and they will have UTIs and stuff. Does that make sense, folks? Right? Because the kids didn't develop a valve. After 7 to 10 years of age, the valve develops. That's a normal anatomical development. Is everybody clear, folks? But there are people with some defect, even after they have become adults, this valve is not developed for whatever reason. The valve is not developed. So now what happened? Even a little stretch of the urinary bladder will send the urine back, having a retrograde flow. Is that clear, folks? Now, when that valve doesn't develop, we call that vesicoureteral reflex. So when people have a vesicoureteral reflex, the valve did not develop. That's what the word vesico mean, urinary bladder. Ureteral mean ureter, reflex, the urine is going back. So these people should never hold urine for a long time. They should always urinate. So this way they are not expanding in here. Is everybody clear, folks?
Dr. Roy.
Dr. Roy.
Go ahead, Abby.
So is both valves affected or is it unilateral?
Say it again.
So you said there's an issue with the valve, right? Is it both valves?
We cannot say that. It could be unilateral or bilateral, but it doesn't matter. Even if you have one unilateral, the problem is going to be there. Yeah. So that's the idea. Yeah. Go ahead, Monica.
Yes, Dr. Roy, like, is there any role of parasympathetic nerve damage, or it's just the detrusor
It's
muscle?
just a valvular problem. Don't bring nerves in here. When we bring nerves, it's a urinary incontinence and stuff. We'll talk about that separate. But here, it's simply the valve is the problem. Okay, is everybody clear, folks? So that's vesicoureteral reflex. That's the idea. And that's why that, you know, number one. Number two, kids, when kids get UTI, especially female kids, it's not a good sign when you take them to the hospital. You know, the first differential diagnosis is sexual abuse when you take them, a kid with a UTI. That's how they process here. When a kid has a UTI, that's what they suspect first. It's very important, folks. Okay. So that's, but then of course they will find out vesicoureteral reflex and all these things, but you have to be careful. Now,
Can trauma cause detrusor muscle damage?
say it again.
Can trauma cause, like, when, for example, the cycle?
No,
The
I
scenario
don't
that
see
you-
the trauma can cause, but if you see a trauma, they have to have enough evidence to prove it's a trauma. Okay. Now, of course, there's more to that. I'm just saying the basic part. They, you know, not like I'm saying was that's a suspect, right? I had my daughter had a UTI. I had to take her to the doctor. But then when they see it, what's exactly happening, they will see that. If you say it's a trauma, they will see enough evidence, right? But they could identify whether it's a trauma or not. The technology is so good at the hospital, they will identify quickly, folks. And then also, you know, doctors usually they are careful when they have UTI first time. But if you were to have a recurrent back to back, that's where they're suspicious. But they always have it in the back of the mind, but they would not tell you. Okay. Well, I do that too. I think in the same way too, right? So that's exactly. It's okay to suspect than not suspecting. Now, here dilation occurs proximal to the site of pathology. Okay. Serum creatinine becomes elevated if obstruction is bilateral or if the patient has only one kidney. See, that's an important point here. Now, if a patient has a block here, let's say one block here, okay, this is so important, people miss us. If they have one side block, the other side kidney will still excrete your abundant creatinine. Is everybody clear, folks? The only way to increase abundant creatinine, you need to have block at the same time on both sides, bilateral, which is not common to have that, right? Or you could have an obstruction in the urethra where it will back up on both. Is everybody clear, folks? So you either have both ureter blocked or obstruction should be in the urethra so the urine can back up on both sides. That will back up the abundant creatinine. So that's why you have to be careful. If one kidney is involved, it's not going to be, or the patient has just one kidney, the other kidney is removed for whatever purpose, then the abundant creatinine will be elevated with only one here, folks. It leads to compression and possible atrophy of renal cortex and medulla. So that's the idea here, folks, okay? So that's your hydronephrosis. Hydronephrosis is always a complication. Is everybody clear, folks? Nobody developed hydronephrosis as a primary disease. So if you ever come across a patient with hydronephrosis, you should find out what's causing that. Okay. All right. Now, urinary incontinence is part of reproductive, okay, because it's OB-GYN. So usually I keep it for tomorrow when we start reproductive. We will finish everything else. If you have time, we will come back. Now, let's go back here. Let's talk about these things. Now, we have a space, okay. When we talk about UTI, one of the most common issue, right? UTI. Urinary tract infection is divided into two. Upper UTI, lower UTI. Okay, upper UTI and lower UTI. Upper UTI mean infection involving kidney. Infection involving kidney. Lower UTI mean anything below kidney. I'm just going to make it like that, below. Below kidney, that's your ureter, urinary bladder, any of those things, folks, okay? So that's that. Now, when we use the word patient has UTI, commonly we use UTI, right? When layman word says UTI, we actually mean lower UTI, folks, okay? So whenever we say on a regular day basis, daily basis, it's basically UTI, mean it's lower UTI. So, but in the exam, you have to be careful with that. So UTI can be upper or lower. A very specific name for lower UTI, either you say it lower UTI or acute cystitis. Either lower UTI or acute cystitis. You see, nowadays for UTI, you don't even have to go to a doctor's office. You could actually do a video call and get the antibiotic prescribed now, right? It's cheaper too, $30. You don't wait on the line, nothing, right? So why it's so common, but those UTIs are lower UTI. Is everybody clear, folks? Those are lower UTI. The minute you get upper UTI, you need to be admitted to the hospital. Upper UTI get a very severe treatment, okay? Because why? Whenever we say upper UTI, your kidney is involved. So for lower UTI, you go to your family practice doctor. For upper UTI, you get admitted to the hospital. So we have to give a fancy word. We can't just say upper UTI. So we're going to call that pyelonephritis. You see that here? Pyelonephritis, okay? Pyelonephritis is nothing but upper UTI. The infection has gone all the way to the kidney. Is everybody clear, folks? All right. Pyelonephritis.
So
All right.
the sorry, the lower UTI is basically the ureter. Is that what you're
Ureter and
saying?
urinary bladder and urethra. See, when I say below the kidney, whatever the structure you have below the kidney can be lower UTI. Okay. Now, are we clear so far? This is what most of the students knows. Okay, they know to differentiate. You have to be careful. Upper UTI, you could get that infection from two different ways. You could get it from lower UTI, basically from the urine. That's what I'm trying to tell. Lower UTI is spreading upwards. Is that clear, folks? So lower UTI can be untreated. So let's say some people ignore the lower UTI and after a few days it gets, or I'll tell you the most common issue. They take the antibiotic, after 2 days they feel better, they stop the antibiotic, and after a week they get pyelonephritis. The second most important where people miss this, you could get blood infection. Basically, you have infection in the blood that can go to kidney straight through your renal artery. Is that clear, folks? People assume in the hospital, most of the time, don't ever think pyelonephritis is only because of the urinary tract infection. No, they could have a blood infection and that can spread to the kidney. Is everybody clear, folks? So that's that. Now, that separates both. Now, symptom-wise, when you have lower UTI, it's not kidney involved, so everything. No fever, because no inflammation. Lower UTI, it's almost common. Every female would have had at least once in their life UTI, lower UTI. If you see, they would say no fever, no inflammation, nothing. It's just the burning sensation and all those things. Is that clear, folks? All right. But when it comes to upper UTI, it's because kidney is a systemic organ, you always have fever. That's a very good information, folks. Fever. I mean, if I say you have a fever, you should know you have inflammation. We studied now at the point that you can't get fever without inflammation. Is that clear, folks? So because of that, let me erase it. You guys should already know that. All right. I don't have to mention it. So fever can be a very good differentiating factor, symptom-wise, from upper to lower. Is that clear, folks? Okay. Now, I'm going to write one more thing. This is one of the most important differentiating factor by lab. Upper will have WBC cast. Lower, no WBC cast. Because when you have kidney involved, glomerulus, so you have a cast. When you have lower, this is a filtered information, folks. I'm giving it to you guys. Okay. Actually, a lot of, I learned from pathology. Have you guys heard the book Golian Pathology? How many people knows Golian? He is retired. He is the hero when we took step 1. He was the hero, actually, He's one of the guys that he teaches pathology, but he doesn't teach pathology. He teaches everything. He wrote his own pathology. Lang's pathology is his, right? I think so. So he is the only doctor, a professor who teaches that WBC cast, how it differentiate. He's my favorite. Half of the stuff I teach you guys, I learned from him, okay? So that's his WBC cast, folks, okay? Okay, that's WBC cast. So how do you differentiate? Are we clear here, folks? The last part, for lower UTI, we just prescribe antibiotic and you take it. And we usually tell them within 72 hours, they should feel better when they take the antibiotic. And if they don't feel better within 72 hours, that's 3 days, they should come back to the hospital, which means the antibiotic is not working. Is that clear, folks? For pyelonephritis, it's not that simple. Treatment, IV antibiotic. Because why? We need to get the medicine to the kidney through the blood. We need to get it to the kidney ASAP, folks. Are we clear? So that's the idea, folks. So that's IV antibiotic. Is everybody clear?
So everything can lead to pyelonephritis eventually, like I
You
get
don't treat, yes, it can. If you have a lower UTI and if you don't treat them, that's one way to get it. Or you have a sepsis, blood infection that goes to kidney. Is that clear, folks? Okay, that's one. That's one of the key to remember, folks. Now, of course, pyelonephritis symptoms are a little severe, not just fever. If you want one more symptom, they will be loss of consciousness, possibly. They have fluid and electrolyte imbalance. Sometimes they can faint. Okay. That's that. But that's too much for you guys for step one. Okay. We don't need to go that deep. Now, this is the big picture of UTI. Is everybody clear, folks? Now, with that information, we should be able to go through that. Look at this here. Acute cystitis, another word for lower UTI. Everybody clear, folks? Now you should know what does lower UTI means. Inflammation of the urinary bladder, presence as suprapubic pain, dysuria, urinary frequency, urgency. Systemic signs are usually absent. That's what we say. It shouldn't be any fever, nothing, folks. In fact, there shouldn't be even enough inflammation, but it's a very mild inflammation, because if you have inflammation, you should have fever. Risk factor, female, because they have a short urethra. Sexual intercourse, we call this honeymoon cystitis. The reason behind, what is the normal flora of the GI tract? E. coli. Okay. Now remember, anal opening and urethral opening is so close to each other. So if E. coli in the anal opening, it's considered normal. But when the E. coli move to urethra, it's a different location. So it's not a normal flora anymore. Is that clear, folks? So it's a manipulation of the flora. And the catheter, if you leave the catheter for a long time, diabetes, impaired bladder emptying. Remember, we were talking about you are not supposed to hold the bladder. Okay, so that's that. Next, what causes? E. coli, most common, because that's the closest organism that lives next to urethra. Is everybody clear, folks? All right. Now, next, they have the other organisms, Staphylococcus, and then you have Klebsiella, diabetes, all these things, folks. Now, when you go to doctor's office for UTI, they confirm right away, right? What they do, they take your urine sample, they look for nucleoside esterase. The minute they have nucleoside esterase, that tells you have an infection. Or nitrites, they both quickly do. Because they don't even culture. If they do culture, it takes 3 days. You get diagnosis right away, right? So they check your urine for that. If they have a sterile pyruvia, that means it's an intracellular organism. That means they're hiding inside, folks, okay? Treatment. SMPS, like any medication, don't just memorize this one, okay? So that's that. What if a patient is given SMPS, TMP, SMX, and comes back after a few days with a back pain and diagnosis, please type it up. Patient was given SMPS, TMP, SMX, few days later, back pain with dark urine. Diagnosis. Only 2 answers I have. I didn't say back pain. I said back pain. I have 3 answers. That's it out of 12. Patient was given TMS, few days later, back pain, dark urine. G6. We get enough questions on that. Patient was given TMS and then do that, right? So because he is a sulfur drug, you are doing the medication at oxidizing, right? So that's okay. All right, so that's acute cystitis, folks. Now let's go to pyelonephritis. Acute pyelonephritis. Neutrophils infiltrate renal system. So we talked about it. Persistence, fever, flying. That's your first number. Now is your motivation stuff. Causes include ascending UTI. That means over UTI is coming up. Or hemorrhage spread to the kidney. That's exactly what we want to learn. You spread the blood. Okay. Spread the blood. Persistence with WBC. You see that, folks. Right. CT shows some data enhancement. Risk factor. Same risk factor as your UTI folks, basically. Low UTI effects is a similar thing they don't treat it. Complication, they could get weak on the right, which means they are not treated properly with anything. They could get perinephric abscess. Perinephric around the kidney they have us. That's those are big processes. Those are discipline condition. If some patient have pyelonephritis and being admitted to intensive care unit, you should know they have those complications. Otherwise, there is no reason pyelonephritis going into ICU. That's okay, folks. That's the idea. All right. So treatment. Antibiotics. Okay. The treatment is antibiotic. So that's acute pyelonephritis. Is everybody clear? All right. Next, chronic pyelonephritis. Who can get chronic pyelonephritis? Who didn't get proper treatment? Okay. Or recurrent. Some people get recurrent. They have structural problems. So many other things are there. Mostly recurrent or inadequately treated episodes. Okay. Typically requires predisposition to infections. Like a respiratory reflex or chronic obstructive kidney stone. People with kidney stone, of course. Remember, there are people who has a kidney stone but don't have any symptoms. No back pain, no pain of stone, but they have a kidney infection. It's because of that stone. So it will be clear, folks. All right. Now they could have some asymmetric corticomedullary scarring. Okay. Tubules can contain eosinophils. So sometimes when people have this chronic pyelonephritis, the tubules have a lot of eosinophils. When they take a sample, it looks like a thyroid gland. So it's a sample that looks like a thyroid gland. We call this thyroidization of kidney. That's the thyroidization of kidney. Okay. So that's the chronic pyelonephritis. If you know that, you would not miss a question. There's something called xanthogranulomatous pyelonephritis. Just to know the name, what it is, that's all. You'll never come across this. It's a rare, grossly orange nodules that can mimic a tumor. So it looks like a tumor. Okay. It mimics widespread kidney damage due to granulomatous tissue containing from macrophages. That's all it is. Okay. So if you see that word, say it's a nodule that looks like a cancer, but nothing else here, folks. So that's your UTI. Now you see in this section, this page is important. If you understand that page, everything will become too easy. So everybody clear? All right. So
for chronic pyelonephritis, what would be the treatment?
Same treatment, same IV antibiotic, we have to treat it completely. Because remember, the reason is recurrent. You can't do anything. You have to keep giving it. If they have a structural defect, nothing can be done. Every time they get it, you have to give it. Or inadequate treatment, you have to treat it completely, right? So that's the idea. Because it's the patients are known to stop taking medication. I'm sure you guys have done that too, and you feel better and you stop the antibiotic after 5 days, right? So if you went to medical school and if you are making that mistakes, how would you expect the normal people to do not to do that, right? So that's that. All right. So that's your pyelonephritis and kidney infection. Clear? All right. Let's talk about. Before we go through that, we still have some disease. Okay, let's go. Acute tubular necrosis. Get to the acute tubular necrosis. Now, if you see, folks, I'm not going to explain what is ischemic, what is nephrotoxic. We already talked about it. Ischemic means lack of oxygen. Nephrotoxic means something that you filtered is toxic to the kidney, right? Look at that, folks. Examples: aminoglycosides, radio contrast. Okay, cisplatin also does that. Myoglobinuria, hemoglobinuria, all these things causes nephrotoxic or afferent arteriolar constriction, which causes ischemic. Everybody clear, folks? Those are the two types of acute tubular necrosis. Look at this. Most common cause of acute kidney injury in hospitalized patients. It's spontaneously resolved, but it can be fatal. Highlight that. It's a muddy brown granular cast. Okay, I don't know why I missed this. Okay, muddy brown granular cast. You see, that's a one and only disease, folks. Now, what you need to remember, when people get this acute tubular necrosis, there's a 3-stage inciting when they get it, but focus more on the second and the third phase, maintenance phase and recovery phase. When you say maintenance phase, oliguric, that means they're not urinating enough. Oliguric means less urination, folks. It lasts 1 to 3 weeks. Risk of hyperkalemia, because you are not urinating, keeping all the potassium, keeping all the hydrogen ion, and uremia. So that's maintenance. If they give you a symptom, you should be able to tell what phase they are in. Okay, they do in the exam. Third one is recovery phase. Recovery phase is polyuric. That means now urinating more. Polyuric. Bun and serum creatinine started to fall. Everything is getting better. Risk of hypokalemia. Now we are excreting too much of potassium and renal wasting of other electrolytes. I would highlight the potassium. You see, hyperkalemia in maintenance phase, hypokalemia in recovery phase. They have given this in the step 1 and asked which phase the patient is on. So everybody clear, folks? So you should know which phase. Now I want you guys to write this now. Next to recovery phase, there will be something called re-epithelialization, folks. Re-epithelialization. That means in recovery phase, you are bringing more new epithelial cells, right? Because why? In the first phase, we kill the cells, isn't it, folks? That's why we call necrosis, right? So re-epithelialization happens on a recovery phase. You need that word. It's actually an answer for a question. Okay. Re-epithelializations. That's acute tubular necrosis. Now, that's that. Any question to me? Good. Next, let's go back to this previous disease I skipped. Acute interstitial nephritis. I mentioned at least 3 times this word. I mentioned this when we did hypersensitivity pneumonitis. I also mentioned this when we did eosinophilic esophagitis. What does that mean? When your kidney is allergic to something, we call it acute interstitial nephritis. When your lungs is allergic to something, we call hypersensitivity pneumonitis. And when your esophageal area is allergic, we call eosinophilic esophagitis. Is that clear, folks? I keep repeating so you guys don't forget. Now here, it's also called tubulointerstitial nephritis. Acute interstitial renal inflammation, pyuria, azotemia, all things happen. It happened after administration of a drug that acts as a hapten. Basically, it's reacting here, folks. One of the most common drugs that you should know, PPI. Even though anything can happen, diuretics, NSAID, all this medication, PPI seems to be one of the most common drugs that causes interstitial nephritis, folks, okay? Less commonly secondary to other infection. More than infection is allergic reaction, folks. That's the most important, okay? Allergic reaction. Patient comes with fever, rash, pyuria, hematuria, costovertebral angle tenderness and stuff. Sometimes they don't. So keep it simple. It's your kidney is allergic to something that you took it. Is everybody clear, folks? So that's that, okay? Now, we have 2 small diseases. Diffuse cortical necrosis. Diffuse cortical necrosis. Acute generalized infarction of both kidney. Look at that. Both of the kidney is dead. Is it reversible or irreversible? Infarction means irreversible. Is that clear, folks? So likely due to combination of vasospasm and DIC. So you had a renal artery vasospasm or DIC. DIC can cause block, isn't it, folks? So that's the key, folks. Associated with obstetric catastrophe, right? Keep in mind that. DIC, platelet count is decreased, everything else is increased. Okay, so that's the idea here. Next one, renal papillary necrosis. That means your renal papilla is coming off. That's all it is. Gives you gross hematuria. You could see it in the urine. May be triggered by some recent infection or some immunostimulus, folks. Just know the terminology and what it is, right? In my opinion, 100% minimum one question in acute tubular necrosis and possibly interstitial nephritis, but not the other two, okay? That's what I see it more patterning on that, folks. You see, this section is so high yield, I'm gonna come to that. That should be your last topic of kidney. Acute kidney injury, that should go with this. I don't know why they put it separately. If you go to the previous first aid, they have next to each other. That should, you should always put that page number. 626 goes with this. 626 is the one that goes with that, folks, okay? Because when you understand the acute kidney injury, you know the consequences of that, okay? So that's where we're gonna come to that, folks. All right. Let's talk about cyst of the kidney. When it comes to cyst, there's one most important disease, autosomal dominant polycystic kidney disease, autosomal recessive polycystic kidney disease. They both are same. One happens in the adults, the other one happens in the kids, folks. That's all it is. That's the only difference. Numerous cysts. Look at the picture A. That tells you everything. It's like you could pop each of these. Okay, so it's a full of cyst here, folks. Now, numerous cysts in cortex and medulla, causing bilateral enlarged kidneys that ultimately destroy kidney parenchyma. Presents with combination of flank pain, hematuria, hypertension, urinary infection, progressive renal failure, folks, okay? Eventually it will fail. It's a mutation in PKD1 gene. Oh, that's the most common, 85% of the cases, and PKD2 for 15%. They might ask you which one is the rare mutation. They did actually, not in this disease, but some other disease. They asked not the most common mutation, they asked the least mutation because they know student studies the most common ones. Is that clear, folks? So you have to be very careful, okay? So PKD2 is 15%, okay? Complication, chronic kidney disease, hypertension. So when you have a hypertension because you produce increased renin, so now all these complications are there, folks, okay? If they develop hypertension and proteinuria, you treat with ACE inhibitor, same thing, folks. Now, when we talk about the same disease, autosomal recessive, that happens in infant, okay? A similar disease that happens in infant associated with congenital hepatic fibrosis, significant oliguric renal failure in utero. It causes parasequence. We'll talk about what is parasequence. That's the idea. And same complications, okay? Same complication, renal insufficiency, portal hypertension. Why portal hypertension? When you have a hepatic fibrosis, with the kidney, you are also getting hepatic fibrosis. So that's something I will pay attention to. With the kidney is right next to the liver on the right side, isn't it, folks? So when the kidney has issue, it's involved the liver. Liver has fibrosis. If the liver has fibrosis, portal vein cannot go properly inside, and it has portal hypertension, folks, okay? That's autosomal recessive polycystic kidney disease.
Is there any relation with cocaine induced for autosomal dominant?
You're talking about cocaine ingestion? With
There's some bed, which happens first, perianeurysm or vaginal.
This has happened in infants, right? So I don't think any involvement on that. Okay. Now, next, autosomal dominant tubulointerstitial kidney disease. It is also called medullary cystic kidney disease. It causes tubulointerstitial fibrosis, progressive renal insufficiency. I would just remember the name because in this section, this is the most important, okay? Polycystic kidney disease is considered high yield. And of course, this is poor prognosis. If they have a cyst, technically you're losing the tissue that makes up your normal kidney. So the parenchyma is getting destroyed no matter what. And the last part, when it comes to cyst, folks, there's two types of cyst, simple and complex. to make it easy, simple is always clear fluid. Whenever you have a cyst with a clear fluid, you don't have to worry, okay? But if you have a cyst, there is no fluid, it's a solid material. That's a worrisome, that's bad, okay? Whenever you have a cyst full of solid material, that's bad. Simple cysts are filled with ultra infiltrate, that's basically clear fluid. Very common, and we don't need to worry. It's usually incidental finding. We don't have to do anything. But when it comes to complex cyst, including those that are septated means they have walls inside, some solid components, we always remove to exclude renal cell carcinoma. Okay, we remove. So complex is bad, simple is okay. Go to the next page. Recently, this has become a high yield. Renovascular disease, folks, okay? This is important. Look at that, that's your renal artery. Renal artery stenosis, it's a very important disease. If you see proximal 1/3, distal 2/3, they divide the renal artery into proximal 1/3 and distal 2/3. Look at here, folks. Whether it's a unilateral or bilateral renal artery stenosis, it has decreased renal perfusion, which will increase renin and all these things. You should know exactly all the steps why it happens, okay? Main causes for renal artery stenosis: atherosclerosis for proximal 1/3, fibromuscular dysplasia for distal 2/3. You must know that, you have to memorize it. You have to memorize it. So how I remember, proximal mean first, A comes first before F. Is that clear, folks? Atherosclerosis is first, okay, that's the main one. If you know atherosclerosis, you should be able to link smoking. Is everybody clear, folks? Why? Smoking is the #1 risk factor for atherosclerosis because smoking causes endothelial dysfunction, okay? So these are the two main reasons why people get renal artery stenosis, folks, okay? So that's basic. Now let's see what else they have. For unilateral renal artery stenosis, so which means patient has one kidney that, right? So affected kidney will be small, the other size will be big. That's basically it is. Why? Affected kidney is not working properly, but the unaffected is hyper-functioning to keep up with it. So they're always big. Renal venous sampling will show increased renin in affected kidney, decreased renin in unaffected kidney, which makes sense because affected kidney has hypoperfusion that will stimulate renin. Unaffected has no problem, so no renin. Everybody clear, folks? Okay. For bilateral renal artery stenosis, patient can have sudden rise in creatinine after starting on ACE inhibitor. You should know that. Why, folks? Let's talk about this. So let's say when patients have renal artery stenosis, what happened to the renal plasma flow? What happened to RPF? Okay, it's down. Very good. So RPF, less blood flow. What happened to GFR? If the blood that you are getting into kidney less, how can you have increased GFR, folks? I'm talking about renal artery stenosis, AFF constriction. Okay, so decrease RPF, decrease GFR. What happened to filtration fraction? That's constant, okay? That because remember, when both goes in the same direction, it's constant, isn't it? Okay, so that's the finding for renal artery stenosis. What happens if I give a patient ACE inhibitor? Okay, well. What happened? ACE inhibitor. What usually do? No, don't think communicate with renal artery stenosis. Let's say I have a patient, separate patient, I give ACE inhibitor. ACE inhibitor causes dilation of efferent arteriole, isn't it? What happened to GFR? GFR decreases. When you dilate the EFF, we're reducing the pressure, So the blood can easily go out. They are not backing up. Okay. So GFR decreases. Why everybody looks lost, folks? This is EFF constriction. When you have EFF constriction, the pressure build up, so you have increased GFR because it's pushing everything down. When I give ACE inhibitor, it dilates it, so you are reducing the pressure, so your GFR goes down. Okay. So what we are learning, ACE inhibitor causes decrease in GFR. Is everybody clear, folks? So the point I'm trying to get here, if patient has renal artery stenosis, they already have GFR decreased, and giving them ACE inhibitor will make it even worse because they also reduces GFR. Is that clear, folks? So can you prescribe ACE inhibitor to bilateral renal artery stenosis? Absolutely not. You should not, okay? If you are not clear when the arrow goes up and down, you will prescribe. You will shut down the patient's kidney. Okay, careful. So that's what it says here. For bilateral renal artery stenosis, patient can have a sudden rise in creatinine after starting ACE inhibitor, folks, okay? That's the idea. You have to be very careful when we give that. Is everybody clear? Okay, so that's a renovascular disease, and we talked about what type of atherosclerosis and fibromuscular dysplasia, what exactly happening, folks, okay? Now, any question in here? Next, renal cell carcinoma. Super high yield.
So basically, you don't give them ACE inhibitor.
Cannot, no. For bilateral, if they have a unilateral, you can, but not bilateral. Now, when it comes to renal cell carcinoma, first we need to know where does it originate from. Renal cell carcinoma originate from PCT, not just memorize kidney, it's specifically PCT. It originates from PCT. Where does pancreatic cancer originate from? Type it up. Type it up. Pancreatic adenocarcinoma originate from where? Don't type pancreas. I want a specific location. We studied that. No, head of pancreas. No. No. Stop typing head of pancreas. It most commonly happens and obstruct the head of pancreas, but I want a specific structure. It's originated from pancreatic duct. Okay. It originates from pancreatic duct. Of course, pancreatic duct is running from tail to the head, and when it happens in the head, it blocks the common bile duct and everything, but originates from pancreatic duct. Same way, renal cell carcinoma originates from PCT. Is that clear, folks? It originates from PCT. When they originate from PCT, it can invade renal vein. I mentioned this on the first day. It can affect the left side of a testicular vein. Patient can develop varicocele. Is everybody clear, folks? Okay. And then it also spread through the IVC, hematogenous spread, metastasis to lung and bone. Because when this spread to the IVC, you cannot get better metastasis than getting into IVC, because the minute it goes to IVC, it will go to the heart. From the heart, it will go everywhere. Is everybody clear, folks? Okay, that's why it's pretty bad, because by the time we diagnose the patient, it's already spread everywhere, folks. I saw about 3 patients with renal cell carcinoma in the hospital. All 3 of them died. Nobody went home. Okay, they don't make it. There's no treatment currently for this. Manifest with flank pain, palpable mass, hematuria, anemia, secondary polycythemia. What type of polycythemia? Inappropriate, absolute, okay? Because they produce ectopic EPO, erythropoietin. So inappropriate. So the treatment we could do is surgery or ablation for localized disease, immunotherapy. Or you could do targeted therapy for metastatic disease, rarely curative. You see, you cannot cure. All you can do is palliative. Palliative means you support the patient until they die, basically. Okay, nothing can work here. Most common primary renal malignancy. Look at this. The one thing I found, all those 3 patients, I said that they died. All 3 of them were smoker. Renal cell carcinoma are highly associated with smoking, folks. And they have neoplasm, paraneoplastic syndrome. I know it says in this book they produce all those things. I would only stick to erythropoietin, in my opinion, folks. Okay, so that's the most important here. And they have a subtype, what we call clear cell. Clear cell is almost same as renal cell carcinoma, folks. Okay, that's the idea. And they are associated with another brain, another tumor we call von Hippel-Lindau syndrome. We'll talk about that. So that's renal cell carcinoma. Are we clear with that? All right. Now there's something called renal oncocytoma. It is a benign tumor, so it's not malignant, so we don't need to worry. It's originate from collecting duct. See, renal cell carcinoma, PCT, collecting duct, renal oncocytoma. The location is key, folks. Okay. And they have this renal oncocytoma. It's nothing to worry. It comes with painless hematuria, flank pain, and abdominal mass. The most of the time we remove it just to exclude renal cell carcinoma. So we remove the mass so we could check it under the microscopy to make sure it's not renal cell carcinoma. Nobody will die because of renal oncocytoma, but in case if it is renal cell, then it's pretty bad. So that's why we remove this. That's all you need to know about renal oncocytoma. Are we clear, folks? All right. Then we have nephroblastoma. Where did we talk about this a little bit? When we did neuroblastoma. You see the word, write it down next to it, neuroblastoma. It's very similar, next to each other, similar word, neuroblastoma, nephroblastoma. What do we need to know? Neuroblastoma bilateral, nephroblastoma unilateral. That's the first thing should come to your mind. This is also called Wilms tumor. Unilateral flank mass, look at that. It's unilateral, folks, okay? And hematuria and possible hypertension can be associated with loss of function mutation in chromosome 11. And there's some complex. You don't have to memorize, but you need to know some little bit here. WAGR complex, what that means, with nephroblastoma, you have some other diseases like absence of iris, genitourinary malformation, some developmental delay. Then we call WAGR complex. Denny-Drash syndrome with Wilms tumor, they have some other sclerosis of the kidney, dysgenesis of gonads and stuff, okay? The third one, I've seen this in one question somewhere. I cannot really recall where, but they were talking about the Beckwith-Whiteman syndrome, which means Wilms tumor plus macroglossia, enlarged tongue, organomegaly, hemihyperplasia, okay, and omphalocele. So when you see how I remember with Wilms tumor and omphalocele is kind of easy to remember that, folks. And if I see that, that's Beckwith-Whiteman syndrome. How do you differentiate omphalocele from gastrochesis? Type it up. They have 2 different, but I just give me one. How do you differentiate omphalocele and gastrochesis? Omphalocele, seal mean covering, gastrochesis don't have. Okay, that's that. Okay, very good. And of course, midline and the lateral too. Okay. So
Go over the neuroblastoma thing that you said at the top before nephro.
Bilateral always, just to differentiate because it happens next to each other. It's bilateral. Okay. Neuroblastoma bilateral, folks. It crosses midline. Okay. So that's that. Now, before we go to the next 2 disease, we need to know embryology of the kidney. Without embryology, we will not understand this. It's time for us to go to the first page.
Wait, doctor, what's the, because neuroblastoma is adrenal medulla
Yeah.
tumor.
Yeah.
So are you just trying to point out that people confuse them a lot?
Neuroblastoma would be confused with nephroblastoma when you read it fast, and one is unilateral, the other one is bilateral. Now, why they confuse? Not only the wording, even the location. Adrenal gland sits right on top of the kidney. Okay, it's close to each other. Now, when it comes to embryology, you don't have to stress too much. Two things you need to know. Okay, so let's put it in this way. Where do we start? I'm going to write glomerulus, okay, GLO to DCT. So glomerulus to DCT. So you should know all the structure: glomerulus, PCT, thin descending, thick ascending, and DCT. Is that clear, folks? And then the next one, collecting duct. Oh, no, I will write it here. Then we have collecting duct all the way to collecting duct all the way to urinary bladder. All the way to urinary bladder. So glomerulus to DCT, all the structure came from metanephric duct. So metanephric duct give rise to glomerulus all the way to DCT. Is everybody clear, folks? So your glomerulus to DCT, everything came from metanephric duct. Collecting duct to the bladder all the way there, it comes from ureteric butt. You see, ureteric butt and metanephric duct. If you know, you would not miss an embryology question, because the question they give you, they will give you 5 structure. For example, they will give you glomerulus, thick, thin descending, thick ascending, DCT, and they will put, let's say, collecting duct. They will ask which of the following structure originate from ureteric butt, then you should know it's a collecting duct. Is that clear, folks? It looks so easy, but in the day of the exam, it will be confusion. You will be confused with which one, okay? Careful. So that's the embryology. Now, why do we need to know? Anything that originates from ureteric butt, which is your collecting duct all the way to urinary bladder, has the same epithelium, which is transitional epithelium. So all the structure from collecting duct to the bladder, you have transitional epithelium because it came from ureteric butt. Is everybody clear, folks? So when I tell patient has a transitional cell carcinoma, that could be collecting duct, that could be ureter, that could be urinary bladder. Is everybody clear, folks? Any of those structures, okay? So all the structure that from ureteric butt gives the same epithelium, which is your transitional epithelium. Are we good? All right. Now, let's go back quickly. And we'll come back. There's a disease, we'll come back. Okay. Look at these 2 diseases. When we say urothelial carcinoma of the bladder, it's called another name, transitional cell carcinoma. When I say transitional cell carcinoma, that means one of the structure that came from ureteric butt. Is that clear, folks? That's why we call transitional, okay? Most common tumor of the urinary tract system. It can involve any of them, suggested by painless hematuria, no cast. Because why? This is below the glomerulus. Because we start from collecting duct, so no cast. Associated with phenacetin, tobacco smoking, aromatic amines, and cyclophosphamide. There you go, cyclophosphamide. How do you prevent this? By giving Mesna. Okay, by giving Mesna, you could prevent that. That's urothelial carcinoma of the bladder. Next, squamous cell carcinoma of the bladder. Hang on a second. I thought bladder has transitional epithelium. How did we get squamous? That means you had a metaplasia. Is that clear, folks? That means your transitional epithelium is replaced by squamous. Then you have dysplasia and squamous cell carcinoma, folks, okay? What is the histology of squamous cell cancer? Type it up. What do you see under the microscope in squamous cell carcinoma? It doesn't matter. It's the same thing all over the body. What is that? What is the histology? Keratin pearls. Okay. Keratin pearls is the histology. Now, risk factors, infection. Schistosoma hematobium, that's an infection that causes the stress, replacing the epithelium, folks. Okay. And presence with painless hematuria. So this is infection. Okay. So that's squamous cell carcinoma of the bladder. Everybody clear? All right. So that's that. So that's this way. Yeah. Go take a break and come back.